Hello, I'm James Hamblin. I'm a senior editor at The Atlantic magazine. I am honored to be leading a discussion or moderating a discussion today on violence as a social determinant of health. Sir Michael raised some wonderful and elegant ideas, and we're going to talk to some people who are working every day to implement them and what they're seeing on the front lines, and open it up to some discussion for some interaction, for hear about these ideas and how they're actually playing out. You have some pads of paper on your desks, on your tables. If you have questions during, there will be a brief question and answer session at the end. There'll be a period where we'll ask you to raise your hands, and people will come by and collect those. So keep that in mind. And I'm going to go sequentially down the line and introduce our guests and have some brief opening remarks from each. First, we have Dr. Connie Mitchell. Connie's a longtime champion of addressing violence against women within the health system. She's an author of clinical guidelines for addressing intimate partner violence and won the American Medical Association Award for Best Medical Text for her book on intimate partner violence. California is fortunate to have her as Deputy Director for the Center of Family Health in the California Department of Public Health. And Connie, if you could start us off, can you share with us some of your thoughts about how we can address the social determinants that contribute to gender-based violence, and your thoughts as a state health administrator about where you think we may be getting some traction?
All right, thank you. Good morning, everyone. It's nice to see you all. As Dr. Marmot reminded us, violence certainly has an impact on health, both direct and indirect, short and long term. However, I want to take advantage of this moment to say I'm not really sure that it's violence that is a social determinant of health. I think it may be a construct that we might call safeness, which is defined as a lack of exposure to danger. We know that safety is a human need. It's obtained through attachment. It's nurtured through the environment in which we live. Safety needs are just above physiologic needs in Maslow's hierarchy of needs. Most now recognize safety needs as attachment itself, and disruption of attachment is about deprivation of safety. I think that the ACE score, I think that the adverse childhood events, I think there's more. We've identified 11, but I think there's more. These are also measures of safeness. And the higher the ACE score, the lower the safeness, and the more unhealthy one is likely to be. We also need to develop measures of safeness for our neighborhoods and the environments in which we live. And there are efforts to do that going on. In California, we have developed a healthy community indicator. This was done through a series of focus groups that we held throughout the state. And we just asked people, how do you know that where you live is a healthy and safe place? And they too could identify very clear, measurable parameters that they wanted to then use as indices to measure progress in their state. And they wanted the ability to identify particular issues that they wanted to work on, and they wanted to feel empowered, and they wanted to be able to go to their city councils or their county board of supervisors and ask for assistance. And then there was a dual effect in doing that. Not only did you experience that you had that power to do so, but when you saw that change could occur because of your individual act, that had a double impact, that you could learn how to make change in your community, and that you had the power within to do that. Safety can be engineered. There's something that's called the human factor principles on urban design, and they are surprisingly comparable to some principles around creating healthy, safe, and nurturing homes. The first principle is information and orientation. We need to know where we are going, and what the rules are. That's what we hear children saying in a home. That's what we hear. One of the first things that intimate partner violence victims talk about is that the rules of the game have changed. They're walking on eggshells. They don't know what's going to happen next. Hypervigilance is a hallmark of the impact of trauma, waiting and watching because you don't know the rules have changed. Another construct of this human factor design in human principles in urban design is socialization and interaction, that you need to provide in an environment opportunities to interact comfortably, to look out for one another. And we know that one of the first things that happens in violent homes is isolation and separation. A third principle is stewardship and ownership. A well-maintained environment to create a feeling of safety and a sense of pride and wanting to belong. And we know that shame is one of the very important components of continuing, whether it's child abuse or dating violence or intimate partner violence. And the fourth and final one is seeing and being seen. We need to know that others are aware of our presence and we are aware of the presence of others. So this idea that I have value and you have value. So if I don't see you for a while, or I don't know where what's happening to you, because you're isolated in your home, these are things that as we create a safety in our community and people can get out and interact with one another, that these are very much linked. So the sense of safety as an individual, the sense of safeness in our homes, and the sense of safeness in our communities are all linked and supportive of one another. So you asked, what are we doing in my state? We have a Health and All Policies Task Force at the state level where we work across multiple agencies to examine every aspect of a community and how we can look at it through a health benefit platform. We've created best baby zones in 3 different counties in California, looking at socioeconomic development as sort of foundational to best babies. We also do youth investment through life course theory. We have the urban networks to increase thriving youth, the CDC-funded endeavor, a personal responsibility and education program, and we're expanding our California home visiting program. We also have included ACEs in our maternal and infant health assessment, so we now have data on ACE scores in mothers in California. We have over 500,000 births a year. So I hope that answered your question, and thank you.
Absolutely. Thank you, Connie. Next, we have Dr. Anthony Eiton. He's both an attorney and a physician who was previously with the health officer and director of Alameda County Health Department, which has long been recognized for its work to address health inequities. He's currently vice president of the California Endowment, the largest private health foundation in California, where he oversees the foundation's 10-year Building Healthy Communities initiative, which seeks to create communities where children are healthy, safe, and ready to learn. Tony, can you describe some key elements from your Building Healthy Communities initiative that may be relevant to other public health efforts to address social determinants and inequities for gender-based violence?
Sure, and do it in 5 minutes. So it's a real pleasure to be here on this issue, and it's certainly, well, actually, I may not describe it as a pleasure to follow Sir Michael Marmot talking about social determinants of health. He either makes it very easy for me or very hard for me. I can't really tell. But his work has certainly been the sort of the intellectual underpinning of so much of the work that we're doing in California. So some of this may seem a little similar, but I think that the distinction here is that in the US, we don't have as good data on individuals as they do in Europe. So we use proxy measures for essentially economic deprivation or income, and I'm going to show you a little bit of that very quickly, assuming this thing will go forward. There we go. So we like catchy sayings in California, and so we remind people that when it comes to your health, your zip code matters more than your genetic code. And how do we know that? Believe it or not, this is a death certificate. All of you will have one someday. Your goal is to manage the data on this death certificate. But for nerds like me who love data, it's a trove of information about equity. And so on a death certificate, you can tell what somebody died of. You can tell how old they were when they died. You can tell what their race, ethnicity was, and you can tell where they lived. And those 4 pieces of data can tell you a lot about patterns of death in a community. This is the San Francisco Bay Area. That is San Francisco. And this is Alameda County, which is the county in which I was the health officer. And Alameda County is shaped like a boot that is trying to crush San Francisco. And we're going to do it someday. So you can take a death certificate and you can actually look at the boot, and you can look at every census tract or neighborhood in that boot, and you can calculate the average age to which somebody is expected to live. And so we did that in Alameda County using hundreds of thousands of death certificates, and you can do this anywhere. I'll show you some other maps in a second. So those red areas are neighborhoods where on average people live less than 74 years. The green areas are neighborhoods where people live on average greater than 80 years, and the yellow is in between 74 and 80 years. And you can see here that long life is not randomly distributed in Alameda County. The foot of the boot, where the older part of the county is, which is Oakland and Berkeley, have concentrated areas of premature death. And I used to show this slide around a lot. It actually ended up on the front page of the San Francisco Chronicle, and people said to me, I don't want to live in Alameda County. It looks like a really inequitable place. So we decided we had to go do this in some other places. So this is Seattle, this is Cuyahoga County, Cleveland. I don't know if there's anybody from Cleveland here, but there you go. To date, at least in my work, you have the distinction of having the census tract with the lowest life expectancy that I've ever seen. Even lower than Baltimore, Maryland, believe it or not, which is what this map is, where I went to medical school. And Baltimore has some areas where on average life expectancy is in the mid to high 50s. This is Los Angeles County, where they did a similar experiment. This is Seattle, King County. So I'm just trying to make sure that everybody in the room knows that there's something in this for everybody. This is New York City. This is Philadelphia, Minneapolis, St. Paul. So you can do this kind of analysis virtually anywhere you go. And the question for us is, when people are living in environments that look like this, what kind of impact does it have on your health? And once you recognize that this surely has an impact on your health, what kind of strategies are necessary to essentially get underneath all of these various disease manifestations, which are literally symptoms of inequity? And the question is, how do we construct a practice that targets the root causes? And that's what Dr. Marmot talks about, is how do you get underneath these things rather than just trying to treat all of these various symptoms, of which violence is a symptom as well. And so we have young people living in these communities where essentially stress is being incubated. And those stressors manifest themselves in many different ways. But the reality of these situations is that this child did not create that environment. This environment is man-made. And I like to say often that it's man-made, and it will likely be unmade by the work of women, quite frankly. And but we need to set about doing that, and we need to do that in comprehensive, multi-sectoral, place-based efforts that work across wide swaths of the human terrain, not just in these narrow silos. And we hope in our work that we're setting a model for that. It's not easy to do. There's no roadmap for it, but we certainly use Sir Michael's work because it's the best roadmap we have thus far. Thank you.
Thank you, Tom. And finally, we have Catherine Evans, who is working to improve communities. She's a community organizer at Communities Creating Opportunity, which is part of the PICO National Network. She's responsible for base building and managing issue campaigns in the urban core of Kansas City, Missouri. Catherine, your organization's collaboration with Kansas City's Department of Health is unique in terms of how public health departments and community-based organizations typically relate. Could you just tell us a little bit about community organizing and how that works, and about your unique relationship with the Kansas City Health Department?
Sure thing. Good morning, everyone. I'm very excited to be here. So community organizing is about discovering and directing the power of people to transform systems of oppression and injustice, and to develop leaders who can act publicly and powerfully in public decision making. That's what community organizing is essentially about. Communities Creating Opportunity is one of many community organizations in this country that is locally rooted in communities and rooted in that mission. And really at the core of what we do is we value people. We understand that everyone has inherent dignity, and that dignity is often violated by the systems that are designed to oppress and keep people separate. So CCO was founded 40 years ago as part of the PICO National Network to address and confront systems of racial and economic oppression. And we continue to do that in many ways today throughout Kansas and Missouri. Our partnership with the Kansas City Health Department is actually, it's pretty unique in a lot of ways. We are actually located in the Kansas City Health Department, and the Director of Health, Dr. Rex Archer, in Kansas City, he calls himself a community organizing intern. He very much believes in what organizing can accomplish. He believes in the power of people. And in fact, he is a member of a congregation that we began organizing in about 10 years ago. And that's how he first started to understand how important organizing is to addressing some of these socioeconomic factors that cause poor health. The reason I think that our collaboration with the Kansas City Health Department works so well is because we have a sort of shared understanding that powerlessness is what makes people sick, more than individual behaviors, more than our systems of healthcare. It's really powerlessness. It's a lack of hope, and it's a lack of the social and political capital that people actually need to create conditions in their communities that are sustainable for them to be healthy and to make healthy choices. And so our collaboration with the health department means that we are working together to transform those systems by building up the power of people. Now that sounds very abstract, and if I had more than 5 minutes, I would love to talk to you more about community organizing. I think the most important thing for you to walk away with is that even as practitioners and providers, there is a role for you to play. I think Yolanda's story demonstrated beautifully how asking people what happened to them, asking people what's causing them pain, and even if you don't know that you can do something about it, giving them an opportunity to share their story and reminding them that you know that they're human is a starting point. And then, partnering with a community organization like CCO will allow you to do things that you might not have thought were possible in your role. We're not activists, we're not really, advocates. We want people to be angry at the way that things are. And we want to channel that anger into action in powerful and public ways that transform those broken systems. So the Kansas City Health Department can't go and protest a fast food restaurant that's paying poverty wages, because maybe they inspect that fast food restaurant and that would be a serious violation. But they can publish a report on the day that we launch our fast food worker strike that talks about how low wages impact health. And so those kind of creative and innovative partnerships are ways for you to partner with community organizations to confront these systems of injustice in really powerful ways. I'll stop there.
Thank you, Catherine. So to get the ball rolling on discussion, I'd like to come back to Dr. Marmot with any reactions to this, and generally moving in the direction of talking about how public health and government agencies work to specifically support the empowerment of women.
Well, firstly, I was absolutely delighted to hear Connie say that you've got a health in all policy strategy for the state of California. That's terrific, absolutely terrific, because it's getting that recognition at government level that health is strongly influenced by what happens right across all the arms of government is a huge step forward, much to do. And that putting it together, we had in our WHO Commission report a cartoon of the Nutcracker. And we said to get action, you need commitment from the top, and then you need action from the bottom, the grassroots. So what we've just heard is thinking about getting health in all policies accepted by the state, and community organizing. You use the language that putting it into action. I talked about empowerment almost as if it was some abstract researcher's concept. I don't think of it that way. And you use the same language. That's how we get people. We want, what did you say? We want people to be angry, and we want to channel that anger. And then what Tony said was that this clearly is in every community that you can imagine. Some of the more depressing moments I've had in my global travels were in Cleveland and Baltimore. To see the devastation in the burned out parts of Cleveland, well, clearly it was once a great city, great civic virtues, and to see that crumbling before one's eyes, and similarly with Baltimore. And so what you're saying is that no city in the United States is immune from this. There are these very finely grained divisions that follow the social gradient, and the bottom end of that, the 20-year gap in life expectancy for men in Baltimore, is absolutely astonishing. That you could walk from one of those areas, nobody walks, but if you did, you could walk from one of those areas to another in half an hour. And you've traversed a 20-year gap. You've gone from sub-Saharan Africa to Scandinavia in half an hour. Good heavens. And I wrote it down as Connie did. Connie and I both wrote down that this environment was man-made, and it'll be unmade by women. Thank you.
So, Connie, many in this room would argue that we have to address cultural norms, including media, political processes that degrade the status of women before we can make progress on violence against women. So how do we work to institutionalize the value of women?
Well, let's kind of build upon the theme here. I think the secondary status of women is founded in historical social policy, just as racism is founded in social policy. And so the remedy will also be through social policy. So women must not only gain access to levels of power, they must change the rules of the game in order to have fair and equal opportunity for all. So I'll just give you one example. I followed the rules to gain my current position as the Deputy Director of Family Health for the state of California. Got my education, established a resume of appropriate experience, had strong networking, and I had demonstrated my expertise and my trustworthiness. However, on day one of my new job, my assistant deputy director, a woman, very bright, young, raising 3 small children, came to me and she said, I really need to have a Friday off every other week because of my child care needs. And I'm really sorry to come to you on your first day for this, but this is something I really need in order to do this job, but also be the kind of mom I want to be. So, of course, I said yes, without hesitation. And that was one of the first things that I enacted as the deputy director, was a policy of workplace flexibility, of allowing women to feel successful in both their careers and as mothers and as wives, and in whatever our partners, in whatever way that they needed to function, so that the values that they were trying to perpetuate in their home could also be brought forward as they reached different pinnacles of power. So that would be my response to that, and your challenge to all of you.
Catherine, I know you've had some experience in Kansas City working with employers and granting time off as needed for employees, and I wonder if you could talk about your experience working with that and bring it back to how it comes into affecting people's health and relationships, risk for violence?
Sure. So we have been working, we've been clear, I think, for a long time that our economy does not enable working families to raise their families with dignity and to live out their values at home. And so, you know, the great thing about being part of a community organization that's part of PICO, which is a faith-based organization, is that we share a certain set of values with our base, with the people that we organize. And those values allow us to frame very clear moral choices about public decisions. So, as controversial as it might sound, if you support children and you support children's ability to grow up in a healthy and productive environment, then you must invest in their parents. And if you don't invest in their parents, then you're doing the wrong thing and you don't actually support children. And so our values enable us to really frame clear choices like that, and it makes it much easier for us to be clear about the issues that we're fighting for and the policies that we want. So our current collaboration with the Kansas City, Missouri Health Department is around paid leave policy. We exist in a community that doesn't guarantee workers paid leave when they have a sick child or a sick parent, when they have the birth or adoption of a child, or even just, I mean, I'm personally an advocate for mental health days. Sometimes you just need a day off, you know? And this is a very problematic public health issue for a lot of reasons, especially when you think about, you know, our current economy is full of these low-wage temporary jobs in restaurants and retail. If you don't have a paid sick leave policy at one of those jobs and one of your employees, for fear of losing a day's wages, comes to work, then they're at risk for infecting many other people with whatever sickness they're suffering from. So the Kansas City Health Department and CCO are currently working on an analysis, pretty academic analysis of how work conditions and work benefits like paid leave actually contribute to health. And we plan to co-release that report in conjunction with a local campaign to call for a paid sick leave ordinance in the city of Kansas City. One thing I've learned in my 3 years of community organizing is that when you're building power and when people realize that you're building power, the people in power get nervous and they try to stop it, right? So we actually recently heard that the state of Missouri, which is a difficult political context at best, the state of Missouri is considering a preemption bill that will preempt local municipalities from passing paid leave ordinances. Which is, you know, it is frustrating, but I'm confident that we have enough of a base of people, not just in Kansas City, but throughout our state, who are going to push back on that and who are pushing back on that. And that didn't happen accidentally. That took years of relationship building, of clarifying our interests, clarifying our values with the people that we represent. And in doing that, I believe that we actually will win a paid leave ordinance in Kansas City.
One of the things that came home to me when we were conducting the WHO Commission on Social Determinants of Health is that all, he paused, waiting for lightning to strike, all social advances come from collective action. They don't come simply from individuals trying to improve things for themselves. And the Commission had a meeting hosted by the Self-Employed Women's Association in the Indian state of Gujarat, in Ahmedabad, in 2005. And I went back to Ahmedabad in February this year, invited by the Indian Medical Association. They were slightly annoyed. I said I wanted to visit SEVA, the Self-Employed Women's Association, again. And my colleague, Mirai Chatterjee, who's one of the conveners of SEVA, took me back to where she'd taken me 10 years before to see the vegetable sellers on the streets of Ahmedabad. And if you want to think about disempowerment, think of these women whose mothers were vegetable sellers, and likely their grandmothers before them were vegetable sellers, and they are the poorest, most marginal women in India. They sit there in the market with a rag, with a small pile of vegetables, and they sell a few vegetables. They get ripped off by the wholesalers in the vegetable market, which is round the corner, and the wholesalers in turn rip off the growers. They buy from the small farmers at low prices and pass it on to the retailers. So these women have to borrow money at extortionate interest rates, 20% a day. SAVER got organized, the Self-Employed Women's Association. It is a trade union. I know that's a dirty word today, trade union. You remember those? They used to be workers, improve things for workers, remember? And in fact, arguably, I divert, but arguably, the reason Thomas Piketty points out that the returns to capital are so much greater than the returns simply to working for a living is because of the decline in trade unions. That we can employ people in miserable ways because there's no collective action to stop it. Well, SAVER is a trade union for these poor, disadvantaged women. SAVER started a bank. It started a bank, the SAVER Bank, to lend to these women at reasonable interest rates. It's not a charity, it has to make money, but poor people pay back their loans. It's only rich people that don't pay back the loans. You know, if the bank lends you $100, the bank owns you. If the bank lends you $100 million, you own the bank. It's very clear. So SAVER started a bank. SAVER became the middlewoman in the wholesale vegetable market. The men, the other wholesalers, tried to force them out, but there they were. They had the last slot, but there they were. What happens to the children? Well, they were sitting with their mothers in the monsoon rains and the heat of an Indian summer. SAVER started childcare. I visited their childcare place. It's not the most luxurious that I've ever seen, but it was heartwarming. And they brought one of the mothers over to talk to me, and it struck me that one of the SAVER workers, forgive me, kept putting her hand on the shoulder of this mother. I was trying to figure out what's that about. Then it dawned on me. All of these women are Dalit, outcasts, untouchables. The reason that she was doing this, she was making a point. To me, this is proportionate universalism in action. It's bringing these women into the mainstream. And my colleague Mirai took me back to the vegetable market, and this looked like an elderly lady. Turned out she was probably around 50, but she didn't know when she was born. And this elderly lady said in Gujarati that she remembered me. I said, how is that possible? 10 years. She hasn't seen another white man in 10 years. But her granddaughter, so her daughter works in the market, but her granddaughter is being educated. Her granddaughter wants to go to college. That is empowerment of women.
I want to bring up something that hasn't been explicitly said that you might, I want to bring up something that hasn't been explicitly said, but something that you're probably aware of. And that is when we think about disadvantage or we think about advantage, it tends to be cumulative. So if you have early experiences that the world is not a safe place, or later experiences, or you're not getting an adequate education, or you're below minimum wage with your job and struggling every day just to survive, and you can't access healthy foods, this becomes cumulative disadvantage, and likewise occurs in the opposite, that you can have cumulative advantage, and thus what we end up with is this huge disparity. And I don't think that, you can only take so much. And then what happens when you have this cumulative disadvantage is hopelessness and despair. And that's probably what is the saddest thing, to look in the eyes of someone who has this sense of hopelessness, that they not only are acutely aware of how downtrodden they are, but they have absolutely no idea of even the first step to try to make it better.
Sir Michael, you mentioned that your story was not a charity. We've talked about governmental policy. We've talked about cultural change. I wonder if Tony can talk a little bit about the role of philanthropy in social determinants of health, in sort of ameliorating some of these inequities.
Yeah, thank you. So, I'm, although I work at a foundation, I don't consider myself a philanthropist. I still consider myself kind of a physician, public health physician, who's committed to trying to understand some of these inequities and coming up with strategies to undo them. And I believe that the role of philanthropy ought to be to take risk and to try things that government can't quite do because government is politically constrained. And I don't believe that philanthropy takes enough risk. And I think, and I encourage people to encourage philanthropy to take more risk. Philanthropy, for the most part, the way it's organized is that you have a bank account, like an endowment. And the IRS says in order to remain essentially an untaxed entity, you have to spend 5% of your endowment every year. So foundations try to raise more, typically through investments, than 5%, because they have to spend 5% and they want to keep growing their endowment, which seems to be kind of logical, but that 5% that you spend in grants is only 5% of your value. You also are making investments, and those investments can actually be targeted to the kinds of community-level investments that enhance your mission that you're trying to use your grants to fund. So at the California Endowment, I think one of the reasons that I work there, I wasn't particularly attracted to philanthropy, but one of the reasons that I decided to go work there is because it feels kind of like a private public health agency. And we have been told by several external evaluators that we're the country's biggest funder of community organizing. We fund PICO and a variety of different organizations in California because we believe that the core recipe to doing this work, and this is for you too, James, in the media, there's really three things that you need to do. One is, at the community level, you need to build social, political, and economic power and a critical mass of people living in these communities so that they can actually change the status quo power dynamics. And that actually comes right out of the World Health Organization's Commission on the Social Determinants of Health. So social, political, and economic power, particularly amongst those that are most impacted by inequity, so that they can help reset the priorities in the agenda locally and make it relevant to their needs. But we think that that by itself is not sufficient. We also have to engage in looking at the health impact of non-health policies or health in all policies. We fund the Health in All Policies Task Force in California, and we work at the local level to try to do the kinds of health impact analysis and health impact assessments, as well as using GIS, like those maps that I showed you, which actually take relatively kind of stodgy looking data and make it more relevant to policymakers. We think that that's not enough by itself. The third thing that we think is important, which is why I'm referring to you, James, is we need to change the narrative about health. We need to stop talking about health just as health care and personal responsibility, which is not to say that those things aren't important. They are important, but they're just not sufficient. And we have to look at the environmental context which we've constructed largely through policy or oftentimes through the absence of policy in the face of abject need. And we have to understand how to reshape that environmental context to optimize health opportunity, particularly for young children and families. And so, you know, that those images of East Baltimore, where I went to medical school, and of that child living in East Baltimore is really the image that motivates me every day in my work. And recognizing, again, personal responsibility didn't put that child there. That child did not create that environment. And if we don't own that responsibility, then we as a society don't deserve the fruits of all of the potential that we're squandering in the human capital that lives in these communities all throughout the country. So I think that that's the basic recipe. It's about power, it's about policy, and it's about narrative.
Catherine, I'm hoping you might have another example from Kansas City about how this has played out in terms of community engagement and actually building power.
Sure. It's very clear that you've spent a lot of time with Pico. You're talking about power and narrative. I love it. Yeah, I think that, you know, when it comes to like trying to change big systems, right? I mean, like, we're talking about racism and sexism, we're talking about spatial oppression, we're talking about all these really big systems. It's really important for us to be clear about what are the prevalent issues in our communities that are giving people the most pain today, and that we can fix, that we have the power to fix, and to have a clear analysis about power and how power works so that we can actually be effective in making that change. And sometimes, you know, ideally, our success is defined by what we win. What are the policies that we're able to change? What are the practices and the programs that we're able to implement that give people some hope? But sometimes, just as Dr. Eiten was saying, it's about the narrative shift, and sometimes changing the way people talk about things is enough to really get the ball rolling. So one example that I like to point to is our long-standing fight in the state of Missouri to lower interest rates on payday loans. Sir Michael was talking about 20% interest per day in that story. In the state of Missouri, the average interest rate on a payday loan is 500%. The legal limit on a payday loan is 1,950%. We live in a state that is ruled by money. There are no limits on campaign finance, no limits on lobbying. And so the payday loan industry, which is a multi-billion-dollar industry, has significant power. Sir Michael, we do live in a democracy, but it's ruled by money. And so moneyed interests really drive public decisions, which is not democratic at all, and we all know that. So in the state of Missouri, we've worked for more than a decade to figure out how we can lower interest rates on payday loans and give people some relief. You know, when people are in desperate situations, when they are in an intimate partner violence situation and they don't have any economic capital, the choice that we give them is a payday loan that has a 500% interest rate. That's not a good choice. So we've been trying to work and figure out how we can make fair credit, accessible to everyone. In 2012, this had to go. We couldn't do it through a legislative action because the legislature wasn't having it. They were already bought and paid for by the payday industry. So we had to go and gather 350,000 signatures across the state of Missouri to get this qualified for the ballot. Ultimately, the payday loan industry was able to tie us up in some legal battles. They sued us, this tiny little grassroots organizing agency, they sued us, which, again, when we start to build power, the people in power get scared. And they had the resources to tie up our campaign. And ultimately, and heartbreakingly, we were not able to qualify that issue for the ballot. And that was a heartbreaking loss for the many, many people whose stories we knew and understood, who had lost their homes, some had lost their lives because they were trapped in the payday debt cycle. So it was a devastating blow, but it made clear to us that, one, we have to reform the ethics system in Missouri. We cannot allow money to run rampant in the state of Missouri anymore, and so that's our next big structural fight that we'll be taking on. I think it also, from a narrative perspective, has created a lot of buzz about how predatory these loans are, and we now have actually federal support from the Consumer Financial Protection Bureau, and they're now working on figuring out how to ban online lending, how to assess a borrower's ability to pay before they actually grant a loan. They're trying to bar payday loan shops from accessing borrowers' bank accounts. So we might not have won in Missouri yet, but the way that people are talking about these loans and the impact that they have, particularly on low-income people, people of color, and women, those are the groups that are most impacted by these loans, is going to eventually, as long as we continue building the base, building relationships, making clear those choices, right, what's right and wrong, that we will one day win.
Mm-hmm.
Thank you, Catherine. So we're going to move to the questions very shortly. If you have one written down, if you could raise your hand, someone will come by and pick it up. Before we do, I want to come back to Sir Michael for one last word. We've discussed a lot, but if there's maybe one thing you could take away from what's been discussed about what we can do to move forward on the issue of violence or safeness as a social determinant of health in the U.S. and globally.
One word. It's never happened to me my whole life.
No, one key idea that we're taking.
Well, I think the key idea that we've all been saying in one way or another is that focusing on the social does not mean neglecting the individual, and focusing on the individual does not mean neglecting the social. We need to keep the reality of people's lives in our focus, right at the center of our focus, but not dealing with the inequities in power, money, and resources, which we said in the Global Commission is driving the inequities of daily life, is doomed to failure. We can't ignore those things. They are the reality. And gender-based violence is one, but not the only manifestation. Ill health, and ill health that's much worse than it ought to be, is another. And my whole push, for what it's worth, is to argue to people that it's actually the health consequences of these policies that ought to capture the attention of politicians in these different domains.
So our first question from the audience, and I'll leave this open to whoever would like to field it. Should the U.S. consider reallocation of healthcare spending for preventive public health measures?
Yeah.
Yeah. Anyone disagree?
Well,
yeah.
I will say this. Is this on? Yeah. That there are a lot of entrenched interests in the healthcare industry, the $3 trillion industry that we have, that are, these are not evil people. They're, contributing to an industry that has developed, downstream in sort of the treatment industrial complex. And I think that the key is not to go to war with those allies. The key is to create virtuous cycles where you can actually find ways to align the incentives of the healthcare sector with prevention and reward the healthcare sector for prevention so that the healthcare sector starts to move upstream to capture outcomes that actually reduce the burden on the downstream healthcare systems. And there are now some innovative efforts around what are called the general field of pay for success or pay for performance, or social impact bonds, which actually allow for preventive interventions to be funded when they prove themselves to save money downstream. The savings are shared back with the prevention provider, so that prevention provider can continue to invest in further prevention, and that creates at least the potential for a virtuous cycle.
I want to piggyback on that too. Very recently, I was asked by Kaiser Permanente to come and speak at a national meeting, their Clinical Management Institute, and they presented the problem to me that with the Affordable Care Act, they had brought in millions of new enrollees that were very different from their previous populations. You know, Kaiser was principally an employee-based insurance plan, and some people who came in were employed. And now they had this new group of people, many who were not employed or marginally employed, and they already realized that their previous system of providing care was not going to be as effective with this particular group of people, that they needed to bring in, and they specifically asked me to talk about the social determinants of health and what could they do as a payer organization, a health payer organization, and their healthcare providers to meet the needs of this new group of people, so that they could, if the need was housing, if the need was food, if the need was transportation, that they would build in within their system the ability to meet those needs. Otherwise, they knew that they would not be seeing the kinds of health outcomes that they had previously been so successful in getting. So I want to echo that it's not a us versus them, or there will be some shifting, but I think there is an acute awareness in the healthcare industry that it's not going to be one more gadget or gizmo, although that's going to be a very strong voice, but it is going to be kind of shifting some of our ideas around what is it that this person needs in order for them to be as healthy as they can possibly be.
Let's move to another audience question. The World Health Organization found that public awareness campaigns are ineffective in reducing violence. So how do you effectively, quote, change the narrative?
Well, I think that it's a more general question. It's not just in reducing violence, but simple public education is necessary but not sufficient to improve health. I don't know anyone who's ever lost weight because her doctor told her to. Simply conveying information is insufficient. We have to change the environment. Think about Tom Frieden's pyramid. I'm at the bottom of his pyramid. I'm sure that wasn't deliberate. But think about Tom Frieden's pyramid. We've got the social conditions. What was next? Making healthy choices the easy choices, or a version of that, and then individual behavior. So information's important, but it's not enough. We've got to change the conditions, and whether it's by community action and empowerment. In your story, we've got payday loans in our country, which are the same miserable, immoral situation, and it's difficult to get it changed, but it's got to be done by legislation. So whether it's by legislation or community action, that public education is not enough. And changing the culture and environment, I mean, it comes back to what you said about individual responsibility. One Minister of Health in Europe, when I was doing the European review, said health is a matter of personal responsibility. We should move away from all these social determinants. That's not for health people at all. And I pointed out her country was at the top of my well-being ranking for children because it had the least inequalities and the best conditions. I said, what are you trying to do? Pull the ladder up after you. And don't blame the children. Don't blame the children for the environment in which they were born and nurtured. It's not just personal responsibility. So somehow public education feeds into that personal responsibility narrative. Well, if only you had the information, then you behave like a better person. Absolutely rubbish. Absolute rubbish. If you didn't have a handgun, you wouldn't shoot anybody. Let's change the environment.
Can I add a comment to that, James?
Sure.
I think that you have to think about what creates narrative, right? So it's not, dominant narrative doesn't just appear out of nowhere, right? It's based on our own biases, our own prejudices that we sort of that are sort of reinforced in the media, reinforced in public life. And so I think the essential ingredient to deconstructing a dominant narrative is actually being in relationship with people who have stories that make that dominant narrative false. So, you know, I think all of us were moved by Yolanda's stories. I came into organizing because of the story of a dear friend of mine who was caught in a payday loan debt trap, and she was considering committing suicide. So it's not just, you know, public awareness campaigns are important, but I think what's more important is being in relationship with people who are impacted by these issues and letting that move you.
Thank you so much. We have to wrap there, unfortunately. We're out of time, but can we give all the panelists a round of applause? Thank you so much.